quality of life. And it's usually egocentric. What's that? Self-centered. They think that whatever's happening to them is not their fault, right? They tend to blame who? Others, everybody else for their problems. Very difficult to treat. It's very trying for mental health professionals. Why do you think?
Because they don't get the truth out of the person.
They may lie to them, that's right. But these patients tend to be very needy. They try your patience. They're the ones that follows you down the hall. They're constantly asking you questions. Do you like a patient that's on the call bell every 5 minutes? It's all right. It's all right. We're just getting started. These patients generally just want to be loved, like everybody else. These patients make a very good first impression, but that quickly wears thin. Okay? Oh, I went right past my little funny extra. Did anybody watch that? Alright, y'all just have to go back and watch that on your own time. It's funny. Miss Hyde liked it today. Oh, we got some military people with us today. So, there again, comorbidity, substance abuse. How many of your patients have you seen in psych in the last 2 weeks have issues with substance abuse? Any of them? Whether it's alcohol, illegal drugs, whether it's marijuana, cocaine, crack, meth, whatever. So, primary antisocial addicts. Do you know what that is? Did you read what that was? Or nope, I was studying for my test. The behavior is independent of the drug use or that need to obtain the drugs. It's independent. So what do you think secondary is? It's related to that drug use. This is where people go in and they will rob and beat up a store owner to steal the money to go do what? Buy drugs. Patients that tend to have psychotic episodes usually have personality disorders. Patients that are depressed and have that suicidal behavior, a lot of times they have personality disorders. And then people with PTSD. How many have dealt with some PTSD while you've been doing some psych? Okay. So our risk factors. Family history of mental illness. Do you think mental illness runs in families? Yes. History of child abuse, neglect, or any other victimization. So if you have a patient that has PTSD, a lot of times when we talk to these patients, they've either had physical abuse when they were young. I know last year we had a lot of them that had histories of sexual abuse, either to themselves or they were sexually abusing children. Instability in the family life during childhood. Why is that important?
Because a lot of your kids who don't have father figures don't have...
No father figures. What about coping skills? Some of them don't have mothers either. Coping skills. Teaching someone values, morals. But what if your parents are drug addicts? Are never home. They leave their kids at home. Patient history of any other mental illness or conduct disorder. Those are some of your risk factors. All these people have personality disorders. Did you know that? Have you read any about your personality disorders or just the one that you have to present today? Okay. So, what do you think Saddam Hussein would be? He could be narcissistic.
Antisocial.
Could be antisocial. What about Marilyn Monroe? Borderline personality? Because usually borderline personality, they have those risky, either sexual behaviors, they do drugs. Amy Winehouse. What? She did drugs. Angelina Jolie. What do you think she is?
Bipolar.
Bipolar. Anorexic. Lindsay Lohan. Probably a lot of the women are borderline. Alec Baldwin. Yes, he definitely has some anger management going on. What personality disorder do you think he has? Narcissistic. Alright, personality disorders are divided up into 3 types, clusters. So think of grapes. Cluster A is odd or eccentric. Cluster B is dramatic, emotional, and erratic. Cluster C are anxious or fearful. Okay. So, on our cluster A's, the only ones I need to go over, because someone has paranoid, correct? Schizoid. No groups have schizoid, do they? Okay. Schizoid personality. They're usually loners. They prefer activities by themselves. So when they go into social situations, it causes them anxiety. Okay? They don't like to be in big groups. Who's at the door? Somebody need in? Okay. They're stable, but they have a limited range of feelings. They usually have a flat affect. What's a flat affect? Shows no emotion on their face. Have you seen some patients in the last couple weeks that have that flat affect? Okay. They don't express their feelings. They're like emotionalists. Their thoughts are very vague. They have no close friends. They do not want to be in relationships. So that marks out family, friends, boyfriend, girlfriend. They're not influenced whether you praise them or you criticize them. Okay? May do okay at work if the work is by themselves. So where do you think these people could work? Some type of office job to where they're not having to interact a lot. Jason says telemarketer, but they're still having to talk to somebody, so that may not be the best thing.
Maybe manufacturing.
What?
Postman.
Postman. Although if they don't get something delivered, they might go off on. You hear about them postmen? They might go off. Somebody go in the post office and go off. Lack of attachment. So then we look at our schizotypal personality disorder. These people are very peculiar. Okay? Not severe enough to be diagnosed as schizophrenic. But what can it lead to? Schizophrenia. They can become psychotic quickly under stress. So there again, they don't have those coping abilities. Something happens that sets them off, and they are going to bluff. Have you seen any of these yet in sight? Not yet? Are you hoping to see some of these? Odd appearance, thinking, behavior. Their speech is very odd. They may have their own little speech. Have you seen patients that have their own little language for things? Yep. Their affect is very constricted, very inappropriate. There again, this type of person, they don't like that social interaction. So if they've got to get into a group, they become what? Anxious. Okay? They're paranoid. They have magical thinkings. And then these are the people that have or see movement in shadows. They're not quite hallucinating yet, but they may see stuff moving when it's shadows. They have a very hard time making decisions. They fear intimacy, and they do not want relationships with others. So any questions on the two from Cluster A? For the ones that come in, there was a couple sheets going around, so if you've got extras, make sure you hand them. Cluster B. I think all these are taken up by groups. Somebody's got antisocial, right? Borderline. Anybody got borderline personality?
Yeah.
Histrionic and narcissistic.
I do.
Joey's got that one. Okay. So we're moving on to cluster C. So someone's got avoidant. Is that correct? Yes. Someone got dependent. All right. So on this one, we're going to look at obsessive-compulsive personality disorder. Okay? This person wants everything to be perfect. They're inflexible. They check and recheck whatever task they're doing. They're polite, but they can be emotionally distant. They have a hard time sharing with others. They're unable to express emotions. Control with them is the central thing. Why is that? They're obsessive-compulsive. This is the people that, want the towels all lined up straight. If you've got candy, it's got to all be the same type of candy in a bowl. They have to have all the colors, right? If there's something in a vase, do they all have to be the same height? Okay. Washing and rewashing of hands. Do you know anybody that has this? Tyler does, or either Tyler has it. Which is it? You know somebody or you have it? You have it. All right. These people are very smart. They fear disapproval or making any type of mistakes. Okay? Only 20% of patients that have OCD, which is what? Obsessive-compulsive disorder, have obsessive-compulsive personality disorder. Okay? OCD focuses on what? That task, that issue, what they're trying to do. Obsessive-compulsive personality disorder is more related to those internal and external relationships. These people, yes, they're focused on a task, but they may start reading a book. Well, then their mind gets on, I've got to wash dishes. I've got to go wash clothes. I need to go clean the bathroom. It's like they can't, everything around them is going to interfere with that. They can't complete tasks. Whereas OCD, you are going to be finishing. If a person, I had a patient one time and they had to wash their hands at least 3 times before they ate. I know people that take 3 and 4 showers a day. Who does that? I don't. Joey takes them once a week, he said. So usually by Friday, he's getting to the weekend, he's got to get his shower.
I'm pretty fresh right now.
He's fresh now. He come off the weekend.
Right.
All right. So then at our little girl here. These are personality disorders not otherwise specified. That's little Miss Passive-Aggressive they showed up today. So a depressive personality disorder. Both of these do not meet criteria to fall in anywhere else. So they get their own little blurb. Depressive says what? They're gloomy. They're unhappy. They're worried about everything. They're pessimistic. They have low self-esteem. Okay? So what is passive-aggressive? Do you know anyone that's passive-aggressive? How many of you are passive-aggressive? No? They resist expectations and demands that others put on them. They're chronically late. Man, that takes care of how many of you? They're forgetful. They procrastinate doing anything. Their behavior is passive on the outside, but underneath, they're very angry. Okay? Does that little girl look happy? No. They're resentful, especially when people try and tell them what to do. Okay? There's no carryover of learning. They don't anticipate and really don't care about the needs of others. So I would hope we don't have a passive-aggressive nurse in here. Because as nurses, we should what? Care about the needs of others. No. They do not have to have all of them. And there again, you would fall back to what? To look at that criteria. And a lot of times it may be, does your patient show 3 to 5 of these symptoms? Okay. Anybody miss the DSM-5 questions? You better not have.
You're going to learn today.
Alright, so our key points with these patients, defense mechanisms used, are repression. What's repression? Stuff it in. They're not letting anything out. Suppression. Regression. Going back. Undoing. So splitting. Have you heard of splitting?
Yeah.
Splitting, the inability to incorporate positive and negative aspects of oneself or others into an image. This is most commonly associated with borderline personality disorder. In splitting, the patient tends to characterize people or things as all good or all bad at any particular moment. Okay? Alright, Jason, read our little quote here. Hey, that's what he said. I was reading something else.
You have your way, I have my way, for the correct way, and the only way that does not exist.
Alright.
Deep right there.
So has anybody ever come to that road sign?
Frederick.
Which way are you going to go? The reason this is put up there is when you are dealing with personality disorders, you have to have rules. Okay? Why do you need rules with these patients? You've got to set your boundaries. Limit setting. Right? What if you are not consistent with these patients? They're going to take advantage because they like to use what? Splitting. So in that case, they're going to be doing what they call staff splitting, where half of you's the good nurses because you let us stay up an hour extra to watch TV, and half of you's the bad nurses because Jennifer's makes me go to bed at 10 o'clock and turns the TV off because that's the rules. So, who are they going to cause problems for? The bad staff. Well, Aaron lets me stay up later. Aaron doesn't make me take my medicines exactly 9 o'clock. Aaron always gives me red fruit punch before I go to bed. Why am I getting orange? That's stuff that can happen. So then, what's going to happen with the staff? It's going to cause conflict with the staff. And do you think the people that are known as the bad staff are really going to get along with the ones that let them get away with everything? No. So there you're going to have problems with staff, which is going to interfere with what kind of environment? Therapy. Very good. See, y'all know stuff. And then, like I said before, these patients are very trying. They're going to push your buttons. But what do you have to do? Stand firm. You may have to tell them no. And mean it. And with this, you can't let one patient do something that you're not going to let everybody else do. Right? And that's what? Justice. Very good. See, y'all learned something. Alright, so just our assessment and our diagnosis. On the left, we have some nursing diagnosis that these patients you could see. And of course, when we're assessing, we're always going to get our full medical history to rule out if there's any medical causes. Do they have a history of SI, HI, or any type of aggression? Okay. What medications are they using? Do they use alcohol or illegal drugs? Do they have a type of legal history? And we talked about a lot of these patients have what? Charges or warrants pending on them. Current past physical, sexual, emotional abuse, and family members that reports patients presenting problems. You know, a lot of times if the family is still having something to do with that patient, you can get a lot of information from the family. Although the patient may say they're the ones that's crazy. Because what? Nothing's wrong with me. So, nursing interventions, what can we do? Safety is always what? Priority. What kind of therapy? What kind of environment? What is that?
Safe. Maintain.
It's safe. Quiet. It's structured. So, cognitive behavior therapy. Have you heard of this?
Yep.
Does anyone know what it is?
Talk therapy.
Huh?
Talk therapy.
Talk therapy. With cognitive behavior therapy, patients learn to reframe that negative thinking, those negative thinking patterns. Okay? So then what is dialectical behavior therapy? You might hear them say they're doing DBT. They focus on patient education, how the patients can prioritize and set goals for themselves. There again, it's still talk therapy. They teach the patients how to rethink their problems and to set goals. So with these patients, what kind of goals do we need to set? Short or long term? Short. Okay. Medications that can be used. Antidepressants. What are some antidepressants that you think of? What's the SSRI? Prozac. They use trazodone, Effexor. Why would someone be given an antidepressant? What's it help with? Depression. What's a lot of these patients have? Depression or anxiety. People that have panic attacks can be given an antidepressant. Alright? Anxiolytic. I don't know how to say that. What is that? Yeah. What is that?
Anti-anxiety.
Anti-anxiety. What is maybe one of the most common? What? Jeff said Ativan.
Zoloft.
Not Zoloft. Xanax. So why would you give someone the Xanax?
So they won't be anxious.
Calm them down. It's going to help with what? Anxiety. Antipsychotics. Dialectical, risperidol, Seroquel. Why do you give somebody an antipsychotic? Somebody that has schizophrenia, yeah. But they are given to help people remain calm when they're under stress. Okay? Well, you know, a lot of times if you look at elderly people, a lot of elderly people get what at night? Risperidol, Seroquel. And it's going to what? Calm them down, help them sleep. Why do you think someone would be given an antihypertensive, such as clonidine?
Helps them relax.
Well, Jeff says when they get worked up, the blood pressure shoots up, so it's going to help control that blood pressure, which is true. But clonidine has been proven to help with impulse control. So they can be put on that. It improves someone's attention span. Okay? Helps them when they're very irritable and they're more prone to behavior problems. Okay? Anticonvulsants. And no, they're not getting them for seizures. There again, these help curb that impulse and helps with people that has aggressive behaviors. So what did you learn today, Joey?
All kinds of stuff.
Why do you give someone clonidine that has a personality disorder? Because why? See if he's listening.
No.
Who can answer?
Impulse control.
Impulse control.
Attention span.
Attention span. Okay, Jason, why is somebody going to get an anticonvulsant?
So they won't like convulse and bite the tongue off.
They're not going for ECT therapy.
Again, it curves.
Curbs your impulse. Helps try and calm down those aggressive behaviors. Because the first time you see an antisocial personality person act out, you're going to be scared. Alright, so develop a therapeutic relationship even though it's challenging due to the patient's distrust and hostility toward others. There again, limit setting is going to be very important with these patients. And we talked about that. Your limits need to be clear and very easy to understand. They need to be reasonable. You don't need to give them some outlandish thing limit. Okay? They need to be enforceable. So what are you going to do if they don't comply? You're going to use what? The least restrictive intervention or environment. Right? And you've got to be consistent with these patients. What you do for one, you do for all. Firm yet supportive. You may have to take some type of assertiveness training. Or everyone in here, can you be assertive? Can you be assertive to doctors, to other nurses? Can you be assertive to patients? Some people say, no, I'm scared to death to call a doctor. But what are you going to be getting very easily? Because guess what? At some point in your career, you're going to be calling a doctor and you're going to what? Get yelled at? You just wipe it off and go on because your responsibility is to who?
Patient.
The patient. Did everybody get that question right?
Yes.
Maintain professional boundaries at all time and communication. There again, we talked about that. You know, if a patient says, you know, you're the only one that understands me, can I have your phone number so I can call you? Here's my phone number, call me. You have to maintain those professional boundaries. And then respect social isolation. So, what we learned at the VA, when a patient comes in, they will let them stay in their room for how long?
3 days.
3 days. So they're respecting that social isolation. That doesn't mean they're not going down there and checking on that patient, trying to get that patient to come out, come to group, join in. But after 3 days, it's going to be what? They're going to need to come out. Because the longer they resist and do not go to groups and show what? Improvement and participating, they're going to be what? They're going to be stuck in there longer. But then again, some people may want that. It's either a warm place or a cool place when it's 96 degrees outside. They get 3 meals, snacks. They get to watch TV. They can play the Wii. They can read books. They can play cards. Now, would you prefer to stay there or do you want to go sleep in the woods because I'm homeless? I can take a shower. I have a bed. Yes, it's bolted to the floor, but I still got a bed. You get a blanket. You got a pillow. You can even get scrubs to put on. Pajamas. Some cute little nice bedroom shoes. Warm socks. So any questions on my